Great. Thank you very much. Good morning. My name is Sam Posner. I'm the Associate Director for Epidemiological Sciences in the National Center for Immunization and Respiratory Diseases at CDC. And I don't expect that to make much sense to you all, but I am essentially the senior scientist in the National Center for Immunization and Respiratory Diseases. And we, along with our colleagues in NCE, the National Center for Environmental Health and the National Center for Emerging and Zoonotic Diseases, work on Legionella together as a cross-center team. And the majority of the presentation today will be given by Dr. Laura Cooley, Jason Kuntz, and Dr. Brian Raphael, talking about the epidemiology, the environmental, and the laboratory aspects of Legionella. I'm going to talk briefly about the background of why we're a sponsor and sort of our interest in this topic. As you likely know, CDC has a long history in Legionnaires disease investigation, starting in 1976 with the first outbreak investigation. And we've been tracking Legionella since then. And what we know is that Legionella is on the rise, and Laura will talk more about the epidemiology of this. And for a long time, our work has been primarily focused on outbreak investigations. And about 2.5 years ago, or 3 years, about 2 years ago, we took a step back and looked at what we were doing and really tried to rebalance our investments and our interest into to look both at response and investigations, which are very important to what we do at CDC, but also what we can do in primary prevention and how we can advance the science and the programmatic activities in prevention. This is, part of what we do is we try and not only respond to events, but prevent events from happening in the first place. And so with that, our interests have really aligned nicely with the charge to the committee. And if you've read the charge to the committee, these areas at the bottom, the 5 areas at the bottom, should look very familiar to you. But we're very interested in the ecology and diagnosis of Legionella, especially and in terms of diagnosis, in terms of how it's diagnosed, what's diagnosed, how fast it's diagnosed, and what kind of tests we use. And in transmission dynamics, understanding what is an effective dose of Legionella and what are some of the properties that make Legionella more likely to grow and spread. In quantification, we're very interested in understanding more of how much Legionella there is and what we can learn about that. One of the things that we've really worked on a lot is this idea of water management plans. And water management plans are very important to buildings, especially complex buildings with outbreaks and preventing outbreaks. And what can we do more to improve the science base that supports our water management plan effort? And this is really something that has been central to a lot of what we've done. And then finally, what are the policy and training needs that we need to understand and improve in order to reduce the burden of disease? And one of the training areas, and Jason will talk about this, Jason Kuntz will talk about this, is the importance of training and working in the environmental aspects of investigations. And so with that, in the interest of keeping things moving quickly, I would like to introduce Dr. Laura Cooley, who will go from here.
Good morning. Great to be here. So I'm a medical epidemiologist on the Legionella team, and it seems appropriate for us, for the 3 of us, me, Jason, and Brian, to present, because this is really how we approach Legionnaires disease response and prevention at CDC, is really with multiple arms, with epi, environmental health, and the lab. So I'll be talking about the epi portion. So I'm sure all of you in this room know Legionnaires disease is on the rise, and this is one of our figures that shows that the rate of reported cases nearly quadrupled from a rate of 0.42 cases per 100,000 persons in 2000 to 1.89 cases per 100,000 persons in 2015. We think that this is an underestimate, as I will talk about in some slides to come. Remy, I just messed it up. There you go. All right. Just testing it out. Okay, so here's a heat map, and this is rates of legionellosis in the United States by jurisdiction. And so I wanted to point out here that you'll notice there's a darker area there, kind of mid-Atlantic to Northeast region. And informally, we kind of refer to this as the Legionella belt. No need really to pay attention to South Dakota. They had an outbreak in 2005. This is 2005. And because of their small population size, it really influenced their incidence, but they're not traditionally a high incidence state. All right, so why are there differences in rates of reported disease? It's a great question. It may be a combination of factors, differences in disease in different parts of the country. It also could be differences in testing and diagnosis practices, but that's actually not what I wanted to show in this slide. What I wanted to show in this slide is that we're seeing increases across the country. So yes, in this Legionella belt, but in other states too. So this is 2010, and if you'll notice, all the states are getting a little bit darker, and then this is 2015. So why are there increases in cases? And with all things in public health, I'm sure it's there are multiple factors at play here. So we know there's an increased susceptibility of population. We have an aging U.S. population, and there are more people with immune suppressing conditions and on immune suppressing medications. There's reason to think there's more Legionella in the environment with warmer temperatures, aging infrastructure, and water-saving building modifications. It's possible that improved diagnostic capabilities are still playing a role. UAT is an easier test. It came out in the 90s, so maybe it's still playing a role in the increases, but it's probably more likely that improved diagnosis and reporting is playing a larger role, increased awareness among both clinicians and public health staff, improving testing and surveillance capacity. So where are people getting exposed to Legionella, and what do we know about source attribution? CDC participated in 27 building-associated Legionnaires' disease outbreaks from 2000 to 2014. And in 2016, we analyzed these data to see if we could find what the common settings and common sources were. And from the analysis of these outbreaks, we found that the most common settings were hotels, followed by healthcare settings, long-term care facilities, and hospitals. And that the most common sources were potable water via showers and faucets, followed by cooling towers, and then hot tubs, decorative fountains, and industrial equipment. So that is very helpful information. The thing is, at least with U.S. surveillance data, most reported cases of Legionellosis in the United States are not associated with a known outbreak. From 2005 to 2009, of all the cases reported in the United States, only 4 were associated with outbreaks, known outbreaks. So the question for that remaining 96%, what percentage of those were associated with unrecognized outbreaks, and what percentage is truly sporadic? There's a variety of reasons why source attribution can be challenging. And so again, this is on this team, we're doing things from multiple angles at the environmental health and lab. And so I've listed here a few reasons why source attribution can be challenging. From the epi perspective, with a single case, there may not be that much of an investigation. It really depends on the jurisdiction. And so to connect the dots and really figure out more about sources, you really need multiple data points. And so the challenges here are that cases are likely underdiagnosed. And then, as I just mentioned, not all cases, even when they are diagnosed, are investigated thoroughly for possible exposures and epidemiologic links. And then furthermore, even if they are investigated, it varies from jurisdiction to jurisdiction whether or not this exposure information is then captured by surveillance in a way that can help public health connect the dots. From the environmental health standpoint, I think the trick here is that there's a special skill set that's needed for environmental assessments and sampling, and capacity for that really varies by jurisdiction. I thought of 2 main reasons why source attribution can be challenging from the lab standpoint. For one, respiratory specimens for culture are not commonly obtained for all cases of Legionnaire's disease in all jurisdictions. Then the second challenge there is if they are obtained, lab capacity for Legionella culture varies by jurisdiction. Our communications department last year was interested in trying to assess in the clinical community what's known about Legionella, what's known about diagnosis, who's at risk, what can be done to prevent it, that kind of thing. And so they did some in-depth interviews. Of course, there was a spectrum, a wide variety of responses, but here are just a few that I wanted to highlight. And these came from clinicians that would be involved in diagnosis of Legionnaire's disease. I don't think I've ever heard the word Legionella. The word isn't even said in our hospital, at least not to me in the ER. Our infection control specialists haven't mentioned it. In healthy individuals, it's relatively low on the list, unless, and this is a big unless, If somebody is significantly ill at any age, if that's the case, it's high on the list, particularly if there's some clinical suspicion due to travel, industrial exposure, or that kind of thing. I would say Legionnaire's disease is not evaluated for the vast majority of patients with healthcare-associated pneumonia. So to address the question of underdiagnosis, one of the things to consider is the current testing algorithm. And is it adequate? So the most recent community-acquired pneumonia guidelines are from 2007, and they list 5 clinical indications for specialized testing for Legionella. And that includes ICU admission, failure of outpatient antibiotic therapy, active alcohol abuse, recent travel, and pleural effusion. So how inclusive are these 5 criteria? There was a group in Rhode Island that looked into this, and so it's a single center study, not that many patients, but basically they took everyone in their center during a certain period of time who had been diagnosed with Legionnaire's disease and you know, any reason that they were tested for Legionnaire's disease. And then they looked back and they took these 5 criteria to see how many of these people who ultimately were diagnosed with Legionnaire's disease would have been recommended for Legionella testing by these 5 criteria. And they found that 41% would have been missed using these criteria for Legionella testing alone. So the VA Pittsburgh healthcare system from 2013 to 2015, they performed Legionella testing by both UAT and respiratory culture for almost all of the pneumonia cases in their system. So that's 98% of the cases. And they found that 44% did not meet currently recommended criteria for Legionella testing. I'm sure you all know that 2 tests are preferred for diagnosing Legionnaire's disease, so Legionella UAT, and that's specific for LP serogroup 1. And then culture of lower respiratory specimens on selective media. So the respiratory samples are really important for a couple of reasons. One is they can detect non-LP1 species and serogroups, and then also having that isolate is very helpful when comparing clinical to environmental isolates during outbreak investigation. So what's happening in practice? And this is US surveillance data. And whenever we get a case of Legionnaire's disease, they report how the diagnosis was made. And to be a confirmed case, you have to have lab confirmation. And so more than 98% that lab confirmation was made via UAT. These aren't mutually exclusive, but total less than 5% of cases were associated with any kind of respiratory isolate. So if there's really this heavy reliance on UAT alone to diagnose Legionnaire's disease, and we know that UAT is specific for LP1, how much non-LP1 disease are we missing using UAT alone? And so a survey of more than 500 respiratory isolates from 10 hospital labs over a period of decades showed that LP1 accounted for 84.2% of isolates, meaning that UAT alone would have missed 15.8% of cases due to other species or serogroups. So then how large is the actual burden of Legionnaire's disease, and how much are we underestimating it? So just for reference, in the US in 2016, 6,141 cases were reported to CDC in 2016, and that's a rate of 1.9 cases per 100,000 persons. There are a few incident studies, but none of them really give the whole picture. So I have 3 that I'm going to tell you about here. 2 on this first slide really are studies only of Legionella requiring community-acquired pneumonia due to Legionella requiring hospitalization. So this is a smaller subset. So the 8,000 to 18,000 number, which I think many of you may be familiar with, came from a study in Ohio. So 2 counties in Ohio in 1991. All the patients that came in with community-acquired pneumonia, they had this extensive battery of tests for all the pathogens. And from their data, they were able to estimate that the annual number of cases of community-acquired pneumonia in the United States requiring hospitalization due to Legionella is probably 8,000 to 18,000 cases a year. And for 1991, that was an adjusted incidence of 7 to 7.9 cases per 100,000 population. So this is helpful, but I think we struggle with how relevant is this today. This was several decades ago, and it was in 2 counties in 1 state. And we know a lot has changed since 1991. So there's a more recent study, the EPIC study, and here is in 2 cities, 5 hospitals in 2 cities. And they did the same thing. They, all the patients that were hospitalized for community-acquired pneumonia, they ran all the tests, and they estimated there's probably an incidence of 0.4 cases per 10,000 adults per year, which is the same as 4 cases per 100,000 adults per year, or approximately 9,500 cases a year. So both of these are more than what we're getting reported through U.S. surveillance data. But they're also, the question is, how representative are these? So the third I want to mention is the VA Pittsburgh study that I mentioned earlier, again, where they tested everybody in their system, so it was inpatients and outpatients, and it was community acquired and healthcare. They tested all the pneumonias, or 98% of them, with UAT and respiratory culture, and they came up with incidences for Legionella pneumonia of 7.99 per 100,000 vets per year, and for Legionella community-acquired pneumonia, 5.99. So again, higher than what we're getting reported through national surveillance. And I think what's clear to us is there really is a need for current representative studies that are nationally representative and not just from one region, because again, as we saw earlier, there are differences regionally, and so we really do need national numbers. And so our colleagues in the waterborne team branch at CDC are actually right now working on a waterborne disease burden estimates for a multiple, I think it's like 23 waterborne pathogens, and this includes Legionella. And so they're starting with the surveillance number, and then they're adding in a series of multipliers. And so one of those is an underreporting multiplier, which for Legionella we don't think is going to be that much. But the big player is probably this underdiagnosis multiplier. And so we've been working with them to try to figure out what the right numbers are to put in there. And so I think they're hoping to have this out later this year, so stay tuned for this. And then just kind of bringing it back around to source attribution and exposure to Legionella. We get these cases reported through surveillance to CDC. What do we know about possible exposures to Legionella? All cases reported to CDC include basic demographic information. But there's a case report form that has additional exposure information, and we found that additional exposure information is reported to CDC for only a subset of jurisdictions. We did a vital signs MMWR last year on healthcare-associated pneumonia, and during that analysis, we found that only 21 of 52 U.S. jurisdictions in 2015 reported what we were calling complete exposure information. And this really just includes exposure to travel accommodations, healthcare facilities, assisted living, senior living facilities, spas and hot tubs, and respiratory therapy equipment. We know a lot of health departments do much more extensive hypothesis generating questionnaires, which will give you much more specific information about possible exposures, but that's not reported to CDC for cases in real time. And so, we think that there is a lot of this information that is being gathered across the country, either for single cases or for multiple cases that possibly have common exposures. But at CDC, since it's not really reported to us, it's hard for us to put the pieces together to know much more about attribution, source attribution at a national level. So what do we think is needed? From the EPI standpoint, it would help to have increased use of appropriate Legionella testing among patients at risk, to make the diagnosis so that we understand the full burden better. At this point, that's UAT and respiratory culture. And some possible strategies could include clinician education and outreach, standing order sets or algorithms for clinicians, and then also maybe infection control protocols for testing that may be independent of clinician orders. Development of better, quicker diagnostic testing options would be helpful as well. And then a better understanding of potential sources of exposure to Legionella, especially for sporadic cases. And so there may be need for increased capacity to investigate cases and identify possible sources and common exposures, and increased capacity to perform environmental assessments and water sampling. And that is all I have. I'll hand it over to Jason Coons from the National Center for Environmental Health.
Hello, Jason Coons here from the National Center for Environmental Health, and I'm an environmental health specialist on CDC's Legionnaires disease team. I come with a background in industrial hygiene, specifically working in the industrial setting and in building water systems. So Laura mentioned about why we feel environmental health expertise is key. So for prevention of Legionnaires disease, we must understand the environmental factors that allow Legionella bacteria to survive and reach the host. And we call this our disease triad: the laboratory, epidemiology, and environmental expertise are needed to control these Legionella-associated outbreaks. And we like to throw communication in there as well. And developing these evidence-based environmental prevention practices will ultimately equal a reduction in disease. However, unfortunately, environmental health Legionnaires' disease experience is inadequate or completely lacking in most of the United States. So what is CDC doing about this? Since 2016, we've partnered with 14 state and local health departments, and you can see the distribution on the map below. Some of them are focused in higher burden states, and we also have geographical distribution as well. And it's called our Epidemiology, Laboratory, and Capacity Cooperative Agreement. And from the environmental health perspective, our goals are to increase Legionnaire's disease response prevention through the utilization of environmental health assessments. We want to have environmental health practitioners proficient in applying the elements of effective water management and that are compliant, with industry standards. We're really trying to develop prevention advisors at the state and local level. So in 2016, we did an MMWR, vital signs MMWR, where we looked at the root cause or environmental deficiencies associated with 27 of the building-associated outbreaks. Laura introduced the concept below, but this gives you a little bit of a peek behind the curtain at more of what we're doing from an environmental health perspective. And in this presentation, I will cover a lot of the committee charges. Specifically, this one, we're looking here around prevention and control, about more effective strategies for preventing and controlling Legionella. So what was important, and which I think came out of this study, is that these investigations revealed that almost all outbreaks were caused by problems that were preventable with more effective water management. And that's where that 9 and 10 statement comes from. So taking a little bit deeper, we developed a classification scheme for root cause analysis around process failures, human error, equipment failures, and then unmanaged external change. That could mean something like a water main break that wasn't managed at the building level. And what we found on these outbreak investigations that CDC conducted is that 65% were due to process failures, around 50% for human error, and then most importantly, we found that about 1 and 2 were due to more than one of the above problems. And I'll go into a little bit of what we found here in a minute. But water management programs, we know, can lead to Legionnaire's disease associated outbreaks. So here's a table from that associated MMWR, and we're looking at the source from potable water here. And we started to see some trends emerge quite quickly. And granted, we have to understand that this is pre-ASHRAE 188, before this came into existence. And typically when you went back and looked through these trip reports and the data to support this, there were really no water management programs in place at these facilities. So we're seeing some pretty common and consistent failures out there, such as temperatures within the optimal range for growth, stagnation due to large amounts of water storage, all items that could be prevented with effective water management. So here's an example of the unmanaged external change here. And what's interesting about this hotel resort here, it did not have a water management program in place. And it had environmental failures in all 4 of the categories. And specifically, there was this unmanaged external change that had to do with a water main break that was not followed by appropriate flushing within the buildings. So it became pretty clear that a little bit could go a long way in terms of preventing these building-associated outbreaks. Okay, so let's talk a little bit about these external factors that can lead to Legionella growth, which is another one of the committee's charge. And so we know from our consults, day in and day out, that we hear about external factors. We know that construction can dislodge biofilm, so can water main breaks. It can cause shearing of that biofilm within a distribution system, which can be released into a building where it amplifies. I think it's important to note here that the distribution system, the public distribution system, is not often implicated in the outbreak, but there are certain factors that can occur in that distribution system, such as disinfectant levels and pH, metal content, presence of other microorganisms, that once it gets into a poorly maintained building water system, it can amplify. And then others too. I put that there because I think that's an important committee charge here. While this may not be something that CDC directly works in, it'll certainly benefit our public health goals and mission to better understand these external factors. Okay, so another one of the committee's charges is to look at the current policies, regulations, and codes out there and determine what is missing, what is adequate, and how it's working. So CDC decided to focus on the ASHRAE Standard 188. This forms the basis of the CDC toolkit. However, since the release of ASHRAE 188, we continue to see other guidelines and protocols emerge, such as the AIHA guideline, the New York City and New York State cooling tower regulations, and very recently, the Centers for Medicaid Services memo requiring water management programs within CMS covered facilities for Legionella and other waterborne associated pathogens. We think that that CMS memo will go a long way in the healthcare environment. Okay, so CDC took our toolkit, took ASHRAE 188 and translated it into plain language. And we realized that ASHRAE 188 was written for the building associated engineer or industrial hygienist. So we put it into plain language, and we gave some examples for people who are considering water management for the first time. We gave some step-by-step guidance for like putting control measures in place, and then we even have some healthcare specific guidance. So this is just one of the main tools out there that we're using to support effective water management. Okay, so where are we at? What's our pulse check currently on water management program uptake? As I mentioned, CMS now has a requirement for these hospitals and skilled nursing facilities. Our colleagues in the Department of Health in the state of Minnesota recently published, as of last week, a study where they looked at 84 hospitals in Minnesota, and what they revealed, and this is pre-CMS memo, 27% had a water management program. And that's not a typo. And if you dig down into the report a little bit more, that water management program may be something just as simple as checking hot water for scalding requirements, and that may be what they're calling themselves a water management program. So when we pulled them a little bit further, 51% had knowledge of ASHRAE 188, and even less had knowledge of the CDC toolkit. And what was interesting is, and I think probably something for us to consider, in terms of capacity going forward, is that there was an overwhelming interest for these hospitals to seek guidance from the health department for setting up these programs. And we're seeing that now at CDC on our technical consults, where these hospitals and other healthcare facilities are asking CDC for additional guidance on setting up these programs and also evaluating them. So we're really seeing kind of a shift out there right now from just advising on water management programs to now evaluating the effectiveness of a partially implemented or a fully implemented water management program. And what's interesting is prior to the CMS memo, in the 12 months prior, we had about 12,000 downloads of the CDC toolkit. And just in an 8-month period following that, we've had 23,600 downloads, and Laura will say that 1,000 of them are from her. Okay, so where are we at? We have a long way to go for uptake. Barriers to implementation include lack of awareness, knowledge, expertise. There's also costs associated with these water management plans and the lack of resources. And right now, there's only requirements from the CMS perspective for the healthcare facility. And buildings or devices in other jurisdictions are really not covered by any type of guidance or requirement for them outside of maybe the New York State, New York City regulations. And our ELC partners are absolutely critical out there right now to promoting the use and identifying barriers and motivators for uptake. And that's the committee charge specifically too, is to identify what those barriers are and those motivations to get these water management plans in place. And we're learning a lot. We're just in the first year or so of this discovery. And a lot of it is being done through trainings and mailings and boots on the ground. And as I mentioned before, we are turning our state and local partners into these prevention advisors. Okay, so another challenge that we're seeing right now in the presence of water management programs is that you take a large healthcare facility with many control points, many measurements, and moving parts associated with these water management plans, and they're generating a lot of data. And in order to really refine these water management programs, we need to be analyzing that data, looking at trends associated with data. We don't want to collect that data and put it on a shelf then we need to be taking that data and doing decision making on that. And that involves engaging the water management team. And it should be ongoing as well, which would be this. With water management, it's more of an iterative process. It's constantly ongoing. But if you're using data on a daily basis to refine that program, that's really where it's at, I think, moving forward with water management. Okay, so what's needed here? And I'll reiterate some of the committee's charges here too. Environmental health expertise is badly needed at the state and local level. And some of the below activities and needs are a little bit constrained by that as well. Research is badly needed to measure the effectiveness of these water management programs. There's a gap out there in the literature currently in this post-ASHRAE 188 environment of how effective are these water management plans in reducing the incidence of Legionella and disease. What are the benefits and gaps and barriers to uptake, as I mentioned before? And while this may not be a CDC function, as I stated, I think it's critical for the public health mission to identify the features of both public and building water systems that make them more or less likely to support Legionella growth. That's an important committee charge. And last, as I stated before, what policy codes and regulations affect the incidence and control of Legionnaires disease, and how can we build these and to improve upon them to protect public health? And then lastly, I still think there's a gap too. Our EPA partners did a really nice job of putting together a literature review on the current state of disinfection strategies in the building environment. But what are those most effective strategies for preventing and controlling Legionella implication in both public and building water systems? And I'll turn it over to Brian.
Thank you. Brian Raphael, I'm the Legionella Laboratory Lead Microbiologist at CDC. And really excited to talk a little bit today about some laboratory considerations around some of the new things that we're learning about Legionella ecology, not just at CDC, but also relatively recent in other groups. And I think a lot of this work has to do with bringing new technologies like genome sequencing and metagenomics to the forefront of research, especially around Legionella ecology. Just to get started, I'd like to talk a little bit about taxonomy and classification, just so that we're all on the same page as I go through this presentation. As many of you know, Legionella is a very diverse genus. There are over 60 species that have been discovered to date. About half of those are associated with clinical disease in one form or another. Over 90% of the cases of legionellosis that are reported, at least in the US and globally, for the most part, are caused by Legionella pneumophila. There's some difference in those numbers in places like Australia and New Zealand. There's several serogroups of this one species. Serogroup 1 is the most common. 80% of cases or more than 80% of cases are associated with serogroup 1. And Laura spoke a little bit about our diagnostic issues, and so some of these cases may be associated with serogroup 1 primarily due to antigen detection in urine. And then within Legionella pneumophila, not just serogroup 1, but within all of the serogroups, a very common technique for typing is sequence-based typing. This looks at 7 housekeeping alleles and allows us to have a general idea of how closely related strains may be that we're trying to compare. And then much more recently, the use of whole genome sequencing has been brought to bear. And I'm going to talk a lot about whole genome sequencing in this particular presentation. But I want to back up a little bit and talk about the ecology of this organism. Legionella is present in a low abundance in natural water supplies. We recently collaborated with a group in British Columbia looking at metagenomic data that they had collected previously, looking at all kinds of microbes associated with natural watersheds in British Columbia. They looked at agricultural watersheds, a forested watershed as well as an urban watershed. And what was common among all of these watersheds was a low abundance of Legionella. What's not shown here, but we did report in this publication, is that Legionella, of the top 50 genera that were identified, Legionella sequences had the highest diversity, sequence diversity, and the highest richness. So it really tells you something about the ecology of the organism that there's in these systems. But it's really when Legionella is present in the built environment where it can amplify and spread to humans, susceptible hosts in the form of aerosols, that, that results in transmission of the disease. We recently reported a study of Legionella in the built environment. In this particular environment were cooling towers throughout the US. In this particular study, we looked at the presence of DNA, Legionella DNA in cooling towers, and over 80% of the samples that we tested, and these were distributed through many different regions of the US, more than 80% of the cooling tower water had detectable Legionella DNA. This would be for any species. About 40% of the samples were positive for the recovery of an organism. And if you look on the right-hand side of this graph, you see that on the top bar graph are the Legionella species that were recovered, a highly diverse population. But surprisingly, Legionella pneumophila in most of the regions that we looked at was the predominant species that we were able to recover. And within Legionella pneumophila, serogroup 1 tended to be the most common serogroup of Legionella that we recovered. But I think it's important to recognize here just the diversity with respect to the species and the serogroups within Legionella pneumophila that were recoverable. We think a lot of work can be done in terms of the environmental microbiome. We took a very small look at this in the particular paper that I'm talking about here that was published in PLOS One earlier this year, actually late last year. We looked at 7 different towers in Florida that we looked at the same towers, one in the spring months and one in the summer months. And what we did here was look at PCR and culture. In the spring, none of the samples had recoverable Legionella, but by summer, some did. But I think what's really interesting about this very early study of bacterial communities in cooling tower water is the diversity of the bacterial communities that were present, both when Legionella could not be detected in the spring, but also when Legionella could be detected in the summer. Legionella was not among the most abundant bacterial taxa present, even when Legionella could be isolated from the towers. You can see that just in 2 of the towers where I have a blue circle, you can see the dark green is where Legionella sequences were identified through our metagenomic testing. I think this gives a very nice idea of the kinds of things we can learn about the ecology of the built environment with respect to Legionella using technologies like 16S rRNA amplicon sequencing, or perhaps even shotgun metagenomic sequencing, which could also tell you more, not just about bacterial communities, but about protozoa, fungi, and beyond. But I want to talk a little bit about what we do at CDC, primarily around investigating outbreaks of disease using whole genome sequencing. This is a group of clinical and environmental isolates that were collected during a community-associated outbreak of Legionnaires disease in 2016. We use a method to analyze whole genome sequences called whole genome MLST. We look for thousands of genes that we have identified through a diverse panel of Legionella pneumophila. And we look for those specific genes in our sequences, and then we can catalog through a database each individual nucleotide substitution. This allows us to identify several thousand alleles for each of the genes that we're looking for, and then we can generate this particular dendrogram that you see here, the outbreak cluster that shows the clinical isolates from clinical specimens along with the implicated cooling tower in this case, the environmental isolates form a very tight cluster. sharing well over 99% of the alleles that I just mentioned. There were several environmental isolates from towers that were not implicated in this particular outbreak, and those are shown in the middle. These are unassociated cooling tower isolates that didn't have anything to do with this particular outbreak. And because such a great effort was sustained in this particular location to obtain clinical isolates, we had several clinical isolates just from sporadic disease that was not associated with the outbreak seen at the bottom. This type of analysis has also produced some very interesting results in terms of the ecology of the organism in the built environment, specifically when we look at over the long term in facilities. In 2015, there was several clinical isolates. Two are shown here of an outbreak in a hospital healthcare type facility. There were environmental isolates collected at the time and then in subsequent years. In this particular set of data, I'm showing three separate years, 2015, 2016, 2017. This was an outbreak due to potable water system. These strains shared over 99% of the alleles over the 3 years, demonstrating the ability of Legionella to persist in complex water systems over time, in this case, several years. There was a cooling tower isolate as well that was not implicated in this particular outbreak by whole genome sequence analysis. What I think is also important to recognize here is that we've seen this in several different types of facilities. This is not unique just to the facility I'm showing here. We've seen this at least in the recent past in probably half a dozen facilities now where we have been involved in investigations, either directly with CDC investigation or through our partners. In working with New York State and New York City Departments of Public Health in their laboratories, we learned more about using whole genome sequencing, about the ability of Legionella to persist and really form what we've termed a regionally endemic strain. This strain was implicated in the South Bronx, very large outbreak in 2015. You can see in the large green circle here, these were clinical and environmental samples that shared 100% of the SNPs that New York State investigators were analyzing. And in this minimum spanning tree, you see a network of very related strains. Some differed by one or a handful of single nucleotide polymorphisms or SNPs. These were clinical and sometimes environmental isolates, and the size of the circle demonstrates the number of isolates that were involved in that particular collection. And you can see here a network of very closely related strains. These actually all share the same sequence type, or as the sequence-based typing alleles. It's just 7 alleles. But here we see that over their entire genome, there's highly related strain that's circulating over time in a particular region. So we ask the question, and we think that this is an important question for diagnostics too, is what makes some Legionella potentially more risky? We know a lot about virulence in Legionella. One of the things is it's a very multifactorial pathogenesis mechanism. You can see here in this electron micrograph that Legionella can replicate in this particular picture within human macrophages. It uses very similar molecular mechanisms to replicate in protozoa in the natural environment as well as in the built environment, sometimes associated with biofilms. We would like to know a lot more about what are the genetic markers potentially that promote these types of pathogenic mechanisms. Do they differ among strains, and can we identify some strains that might be more risky from a clinical disease standpoint so that when we investigate isolates collected from the environment, we can possibly make some kind of prediction around what is their role potentially in causing clinical disease. Not just in terms of clinical disease or virulence, but also what about the possibility that these mechanisms also allow the organism to survive in certain environmental niches. So for instance, does Legionella replication and survival within amoeba, within say environmental water sources, reduce the efficacy of various disinfectants or biocides that might be used. As a very early example of the kinds of work that may address these types of questions, I want to show here some analysis of about 500 sequence type 1 isolates. This is a very common sequence type globally. I'm showing some data here in the bar graphs on the left of clinical isolates from sporadic disease. Sequence type 1 is by far the most common cause of sporadic clinical disease in this particular strain population. And environmental isolates that were not associated with a particular outbreak or investigation, sequence type 1 is very common. When we looked at 500 sequence type 1 genomes that either we sequenced or that we were able to obtain from public databases, we did a complex analysis of the level of variation as you span the genome, and I'm showing this on the right. And I know it's a little bit complicated, but above the x-axis on this particular scale shows regions along the genome where clinical isolates showed more variability within a particular region. Below the x-axis are where regions across the genome where environmental isolates, all ST1 mind you, showed greater variability. And what we can tell from this particular study is that clinical isolates appear to have a restricted degree of variability across the genome when you compare that with environmental isolates. And one of our hypotheses from this particular study is that clinical isolates may represent a subpopulation of environmental isolates, and that we would like to learn a lot more about these regions and could they potentially serve as markers for more risky Legionella that would allow us to have a little bit more predictive value when we get environmental isolate sequences. So some key questions that we've been asking along the way are understanding genetic determinants of dangerous Legionella. How can we identify these genes? It may be not just that we need to understand the particular genes that are involved, but we may also need to understand the regulation of those genes that are involved. Do certain environmental factors turn on particular genes that would promote virulence or survival in environmental niches that we are concerned about? And then how can we focus prevention efforts on specific Legionella of clinical concern? So it sort of comes after really understanding in a lot more detail the ecology of this organism and what could potentially make some populations of Legionella more dangerous than others. And then finally, the concept of endemic strains really leads us to, and also persistence, really leads us to ask questions about the ability to completely eradicate Legionella from a particular environment. And we need to understand a lot more about how Legionella strains circulate in the community and how the built environment can be seeded by these strains. So what's needed? We absolutely need to improve detection and typing, and not just for clinical isolates, but also for environmental isolates. We know that culture can take several weeks, under the best conditions, about 1, maybe 2 weeks, sometimes even longer. We are already beginning to focus resources on culture-independent diagnostic tests to potentially reduce the time to result from weeks to a few days. And this involves things like detection, targeted sequencing approaches, metagenomics, but also getting at the issue of, are there viable organisms there? Are they regulating particular genes? And I think the technologies around transcriptomics is very important in this particular area, potentially also protein level characterization. Would these improvements in culture independent diagnostic testing improve our ability to detect more cases and possibly change our assumptions about diagnostics altogether? We need to develop improved informatics and databases to really use this information effectively on a national scale. Our whole genome sequencing database has a little bit over 1,000 genome sequences in it now. We are working to extend this sequencing platform and analysis to several of our state public health laboratory partners. This will allow us to get a lot more information into a national database. The good thing about something like whole genome MLST or similar gene by gene typing technologies is that data can be shared between and across jurisdictions through centralized databases that can then be screened or queried for particular questions around our particular strain circulating in environments or other ecology questions that may arise. And then finally, we need to obtain a lot more baseline data about the prevalence of Legionella in various settings. Healthcare settings are very different than potentially other parts of the built environment. We need to understand, do certain strains with certain genetic characteristics colonize some settings differently than others? And then we're just beginning to make some headway in the concept of the idea of different strains possibly circulating in different geographical regions. I think the data out of New York is very interesting in this regard about, is it possible at some point to be able to interrogate a sequence and identify with some level of certainty that a strain could potentially be associated with a particular geographical region. And like I say, I think databases are probably making some improvements in this area. I think with that, we take questions.
Join us at the table here. You did very well, and we have time for some questions.
And if you have a question, please approach a microphone or raise your hand, and I'll bring one to you as a courtesy for our online viewers.
Yeah. And I'll go here.
I wanted to just start real quickly and ask about Pontiac fever. And is that something that is being included, or what do we know in relationship to the pneumonia?
I'm guessing I'll field that one. So Pontiac fever for us is not as big of a focus because it's not what's causing death or hospitalization. It's self-resolving. It's important. We think it's important because often cases of Pontiac fever and Legionnaires' disease coexist. And if there's Pontiac fever, there's evidence of Legionella growth in some water systems. So I think it's important to note it, but really our prevention efforts are aimed at Legionnaires' disease, which is the more severe illness. I think our surveillance for Pontiac fever is subpar. I mean, it's not easy to diagnose. And most people, you know, they get better in 48 hours, they may never go to the doctor. So I think we really don't have an idea for what the surveillance burden of Pontiac fever is. I mean, we're interested, and a lot of what we do pertains to it. But I think for those reasons, one is we really just don't have a good grapple on the surveillance. I mean, for us, if we look at all Legionellosis reported to CDC, over 98% are cases of Legionnaires' disease. About like 1.6% are Pontiac fever, and then like 0.4 are Legionellosis other, which are often probably either Legionnaires' disease or Pontiac fever.
Thank you. Joe.
First of all great presentations, lots of great information. Two questions. Clarification on Dr. Cooley's discussion. You said 4% of the cases were identifiable or linked to water, and then there were 96 sporadic, and I'm guessing that means some portion of the 96 are probably also associated with water. We're just not able to pin that down yet.
Yes, and it's associated with known outbreaks. So basically, when someone reports a case to us, there's a box that says associated with a known outbreak or cluster, yes, no. And so when we looked at it for a period of 3 or 4 years, 4%, they had ticked that it was. That's not to say that other cases, I think we don't know of that 96% which have been investigated, and they just didn't include that when they reported, which were associated with an outbreak, but that just never was investigated and the pieces weren't put together, or which are truly sporadic. And I think that's what we would love to get more information about exposures to kind of tick away at that 96%. We definitely think it's more than 4% that are associated with an outbreak.
And then also, there are a couple of pneumococcal pneumonia vaccines out there. By any chance, do any of them have any impact? And if not, are there any vaccines in development for Legionella?
No, and I might toss it to Brian here, but I think the case with Legionnaire's disease is we think it's really important. It's what I spend all day, every day doing, but there are 6,000 cases a year that we know about, whereas there are many-fold more than that of pneumococcal cases of pneumonia a year. And so I don't know that there's any work. We aren't doing any vaccine work on. So all of our prevention efforts right now, in fact, we say it on our website, there is no vaccine, and so it's about preventing Legionella growth and spread through the environment. Yeah.
So thank you for your very nice overview of the situation in the US. I'm from the Netherlands, and in the Netherlands we also have Legionella problems, of course. And I was especially interested to see the whole genome sequencing and comparing the strains from the environment with the patient strains. It's good that you find some related cases, but actually I'm more interested in the ones that are not relating to any environmental sampling, because in the Netherlands, around 70% of the Legionella we observe are sequence types that have never been or almost never been observed in any environmental sample, whereas in the Netherlands they sample the environment of a patient quite intensively. So how is that in the US? Is there any data on that?
Yes, very good question. And we are also working with some of our state partners with sporadic disease isolates specifically. As I'm sure everyone in this room knows, obtaining clinical isolates, especially from sporadic disease, is very difficult. We see some biases throughout the U.S. and our state public health laboratory partners with not just the capacity to do so, but also simply acquisition of the specimens. However, we are very recently, within the past, I would say 1 to 2 years, working with several sites to do sequencing of sporadic disease isolates within the particular state jurisdictions where we're collaborating. And what we're finding is very interesting from the standpoint of exactly what you're saying, that in some cases we're finding new and novel sequence types. We're also learning that in some cases there do appear to be sequences that are pretty highly related that can be associated with some regions, and just as well we can see the intermingling of sequences from very different regions. So we're beginning to really make some understanding around what strains circulate in very widespread, and also what strains might be more in that category of a regionally endemic strain. But a lot more sequencing is needed, and even before we can do the sequencing, of course, a lot more clinical specimen attempts are needed as well. Excellent.
I wonder if any of you have any thoughts as to why we don't see Long Beachii in the U.S.
There are a few reports of Long Beachii in North America and Europe. There are a few research papers on this particular topic. In some cases, especially in Australia and New Zealand, a lot of the Long Beachii has been associated with soil, potting soil, compost. There's some discussion about differences within what materials are used to make up that compost, and how those materials may support Long Beachii versus other competing organisms. I think there's probably a lot more research to do in that particular area, but there have been just a few cases, and I am pretty sure that the ones in the U.S. that I'm thinking about haven't very often been drawn back to with genetic evidence to a particular source. In some cases they have, but it is relatively rare.
Thank you for your presentations. There seem to be some fundamental biases which you've acknowledged to some degree, which is on the clinical isolates, as you mentioned, something like 90% probably coming only when there's a urinary antibody test positive, in other words, serogroup 1. So you've got that severe bias in your databases is what you've got a view on the world from the clinical side. And somewhat equally from the environmental isolates that you have, you're relying on a fairly crude culture-based method that's not really adapted for environmental microbiology. And again, you'll get a severe bias as to which ones will actually be culturable from that source. So when you're comparing your environmental with your clinical, a microbial ecologist would look at that and say, okay, that's one view, but it's not really anywhere near a complete view, which I think you've acknowledged in your presentations. So I guess I'm leading towards where might you be going more with direct sequencing from both body tissues, lung, sputum, materials, direct metagenomic work there and with environmental ones to better characterize and show these relationships.
You're exactly right. There are lots of biases in what we know about Legionella ecology already. I would say there are two main avenues, at least from the laboratory standpoint and possibly from environmental and epidemiology. Feel free to chime in. I would say from the laboratory standpoint, two clear things that we need to understand are you're absolutely right about culture-based bias in environmental ecology, environmental microbiology. What we need is a lot more context. So we need a lot more environmental isolates that aren't necessarily associated with any particular disease to understand are certain populations that we're seeing unique or not, given the region that we're investigating. But I think more to your point is the concept of bringing in culture-independent diagnostic testing, whether that be full-on shotgun metagenomics to understand the entire microbial burden that's there, or perhaps targeted approaches that allow us to get at Legionella specifically and make some characterizations to compare with specimens from clinical sites. In general, our practice has been that it is somewhat easier to get environmental samples and get Legionella from environmental samples, but the implicated organism tends to be obviously from the clinical samples. So even though we have fewer clinical isolates than we do environmental isolates at any given time, it's really that clinical isolate that we get that's so critical because it allows us to do source tracking. I would like to get to the point with the technology to be able to get answers without culture directly from clinical specimens and environmental sources in a lot less time. But go ahead.
Well, I was just going to put a little plug in for the epi side of things, because I think from the response aspect, when we're working with partners on an outbreak, to me, the microdata definitely can support the investigation, but it doesn't replace the epi investigation. So much of what we do is just old-fashioned epi of putting together people at the right place at the right time with the right sources and the performance of the water management program, that kind of thing. So I think there are a lot of pieces, and I think the micro definitely helps clarify, but I don't think, I think there's still a lot we can do even when we don't have isolates.
I just want to second thought on that too. And this is something we clarify every time we do genetic sequencing in the context of an outbreak investigation. In the laboratory, we are relying on epidemiology data, solid exposure data to direct sampling and also to interpret the kinds of genetic data that we're getting. So it's important when you do a full-on source attribution type of study that we are not looking at a dendrogram in the absence of the exposure data. We are in a way trying to support the suspected source from the epidemiology and the environmental assessment of a particular outbreak instead of the reverse, where we're saying, I see a cluster, there must be something going on. It really needs to be supportive of the epidemiology.
Thank you. We have one more question here, and then we have a question online. We're bumping up against lunch, but we'll see if we can get those two in.
Okay, thank you. I appreciate your presentations and especially the acknowledgement of the broader range of issues, including the sporadic cases. there's a lot of momentum that's been built up over the last few years over efforts that were made to highlight best practices within buildings, for example, ASHRAE 188. How do we build some momentum around looking at, the issues related to source water? And I think we keep seeing more and more of that developed. And any water management program that deals with variable water quality coming through the water main is always going to have difficulties maintaining control of the bacteria within the building. So I guess the question is, do we see it as a systemic challenge? And then how do we broaden that effort out?
Yeah, thanks for that question. I think that's an important committee charge here too. If we look at the charter for this committee, is to begin to understand better the role of the municipal water in the incidence of Legionnaires disease. And I think I'll default to our EPA partners, during their presentation, discuss about that. But you're absolutely correct. One of our critical control points in any water management plan is looking at the incoming water within a building, and then responding to that accordingly. So I think there is momentum around that topic, and a lot of that momentum's in this room today.
Got a question online.
So this question comes from Andrew Ward from NSF International. He asks, has the CDC started to see water management programs that include other opportunistic plumbing pathogens and not just Legionella? And he thought this would be a best question for Jason.
So yeah, we're here kind of focusing on Legionnaires disease within this panel because we have to kind of limit it, I think, to some degree. However, CDC strongly supports these water management plans to help with those other associated opportunistic pathogens, whether they're NTMs or Pseudomonas, and our toolkit specifically suggests that. And if you look at the CMS memo that came out, that also calls for those other opportunistic pathogens with a specific call out for Legionella. So, 9 times out of 10, when you're controlling for Legionella, you're going to be preventing towards the other. So yeah, I think CDC supports the NSF International work around some of their standard development of 444, which would cover those other pathogens.
And I will just add one thing to that. I think sometimes the momentum is more with Legionella because there's better clinical surveillance versus the other opportunistic pathogens associated with premise plumbing. And then we happen to all work on Legionella specifically, but at CDC in general, I think is very focused on a broader risk associated with water systems to include other pathogens, not just Legionella.
I see we have 2 more people that would like to have a quick question, and then we'll go to lunch. I think we'll break for lunch.
Yes, thank you for sharing your expertise today. I do have a question. There's been a nice discussion about the important collaboration between epidemiology and microbiology in these outbreak investigations, and also recognition of the need for a broader characterization of the prevalence of Legionella in the environment and down to the isolate level. Do you foresee that the environmental investigations are going to broaden to include and encompass sampling beyond the point sources identified in the epidemiology investigations?
We're just trying to clarify the question among, yeah, what would those sampling points be to help us out?
Currently, outbreak investigations focus environmental sampling on point sources identified by the case patients that are included in the cohort. My question is, now that you recognize the important collaboration between epi and microbiology and the importance of characterizing the whole environment and prevalence in not just a building or point source, but in the region and community to understand whether it's unique to a point source or not. Do you foresee that outbreak investigations will broaden beyond the buildings and point sources identified in the epidemiology investigation?
Sure. Yes, you're right, if I'm interpreting this correctly, that our outbreak investigations have generally been focused on buildings at increased risk, because usually it's based on an epi where more than one person was exposed in one place, and that's usually, a larger building. Again, if we're going to chip away, though, at that 96% and see, what about the other cases? Like we know it's not 96%, but some portion of those are truly sporadic. They're single cases associated with a single point source somewhere in the environment all the way to the home. that is definitely a burning question for us. I think really from our side, it's been a resources question. I mean, we spend all day, every day responding to outbreaks with state and local health departments, but we've been able to expand our program a little bit, and we actually have some momentum towards doing a large-scale sporadic disease study. And so I think there's some other steps that we have to get through before we do that, but there's definitely a question that we don't know the answer to, and we think more research needs to be done to chip away at the rest of that 96%.
All right, I think you get the last question here. We'll make it short.
Thank you. I'm just wondering, when you do your investigations, environmental investigations of building systems, you know, cooling tower systems, where do you sample, and is that important?
Yeah, if you're specifically focusing on a cooling tower, yeah, that's important. And CDC has specific guidance for our sampling protocols published on our website for considerations on exactly where in a cooling tower to sample. And I would all ask that you guys take a look at that, because I could potentially, you know, miss a few of those places. But yeah, it's critical where you sample. Now, we like to deploy both swabs for the biofilm, you know, below the basin pan, and it has some considerations, of course, of whether the cooling tower is running or not, and you know, there's some health and safety issues with that. We like to use bulk water of the water that's recirculating through that cooling tower system. Now, sometimes where it's not feasible to do those two, there are bleed-off valves that one can sample in a chemical control room that can give you a reasonable assumption of what's in the basin, and we do account for those in that sampling methodology.